So if you've seen my presentations before, I apologize that you have to sit through another one of them. So I have no relevant financial disclosures. The only disclosure that I have to put out here is that I'm a panel member for the NCCN Adult Cancer Pain Guidelines, which we'll review. I'm not here in that capacity, so I'll talk about them as if I'm not in that capacity, but you should be aware that I'm on that. So the learning objectives for the talk are to review the current cancer pain guidelines. They're updated annually, and we'll kind of go through just some highlights for you, not the whole document, because they're 99 pages long. And then we'll discuss cancer pain management and the limitations of monitoring for drugs that you may not commonly use, but that you should consider using for certain situations. And we'll kind of walk through one patient case where you might choose one or all of these drugs for this patient. And we'll go through kind of the clinical decision making behind that patient and talk about others. So here's your patient. WD is a 36-year-old male who presents with increased pain around his GJ tube and malnutrition. This is him presenting to the hospital. His notable medical history, he's had multiple cancers throughout his life, multiple surgeries throughout his life. And the two big complaints now are gastroparesis. He had his GJ tube placed a month prior to this admission. And he's had chronic back pain and opioid dependence to treat his chronic back pain, really from his spinal schwannomas. So that's what's driving his case today. His major complaints are that pain. After talking to him more, he has multiple pain generators from the chronic back pain. He's got generalized abdominal pain and cramping, and the initial thought is maybe he has a recurrence of his pancreatic cancer. And then he has visceral pain at the site of his G-tube. And he has significant gastroparesis with nausea and vomiting. And because of this, the GI team has made him strict NPO. To the point that it has frustrated the patient that he can't even eat or anything at this point. So this is what we're dealing with in terms of now how do we manage somebody's pain like this. So keep him in mind as we're going through things. But the first thing we're going to do is just take a look at the adult cancer pain guidelines. They're on nccn.org. They are free. You just have to sign up for a free account. They get updated every year. There's a member from each of the institutions, and I'm not pushing the guidelines, but it's a good place for you to go to if you're not really sure what to do. But I think really the most important part here is I'm going to highlight Pain C, and that's really all we're going to talk about for now. Pain C is comprehensive pain assessment. So how many of you name, without even looking at this, how many pieces of a pain assessment would you consider doing for this patient? What things would you want to think about for this guy? What would you do in your routine practice? Don't read the slides right now. What would you be talking to him about?
What he's used in the past and what's worked.
Okay, so past medication trials, what's worked, what hasn't worked?
Intensity of pain.
Intensity of pain.
Location of pain.
Okay, location.
Location of pain.
Okay.
And how it has changed, he's had these chronic pain problems, and how it has changed and what has made him come to the hospital now.
Okay, so what has changed to make him come into the hospital now versus being at home? Okay, what exacerbates the pain?
Functional status.
Functional status, I think, is probably one of the most important things, right? So that should be the first thing you ask about when you're talking to a patient. Don't ask them what their pain score is, because everybody's pain is subjective. Ask them what are they able to do and what are they not able to do because of the pain. What are they limited by? Get them to focus on activities, not on a score, because we shouldn't be treating a score. And I'll tell you, so these are the 2019 guidelines. The 2020 guidelines that are coming out, we had such a long discussion on them that we had to have a third conference call on them about getting rid of the pain scales, because we really need to be moving away from treating a number. You need to be treating the person and what they're able to do. So there's a 3-question scale that you can ask. It's validated in chronic pain patients, but it works really nicely in cancer patients. So the 3 questions are pain, general activity, and mood or emotion. So it tells you how is their pain, how's their mood, and how's their function. So it's called the PEG scale. The first question is, on average in the last week, what was your pain score, 0 to 10? Let them get it out if they want to get it out. You can also ask that at the end. The second question and third question are scales 0 does not interfere to 10 completely interferes. On average in the last week, how much has pain interfered with your mood or your emotions, right? And the other one is how much has pain interfered with your ability to complete general activities. And so these will give you numbers 0 to 10 that you can average and track, but you can actually see what's impacting their pain the most, and you should be really focusing on their activity. Then follow up that with what activities are you actually limited by? Now, if we're talking things like I can't cook, I can't clean, I can't do regular house tasks, that's significant limitations. Some people say, I can't go ride my motorcycle. You have metastatic cancer. Maybe we need to reframe the discussion here. And I've had patients like that. I've had a metastatic lung cancer patient who was complaining that he couldn't ride his motorcycle for 2 hours. And I'm sitting there thinking like, I don't even know that I could ride a motorcycle for 2 hours. That's your quality of life, but maybe we need to reframe this discussion and have you understand what your new set of limitations are and try to achieve those. The other thing that's on here, we talked about lots about medications, but there's special issues that I think you need to think about as well that often don't jump to the top of what we think of as a comprehensive patient assessment for pain. So what is their social support at home? How are they going to take these medications? If you're going to give them a large abundance of a controlled substance, do they have little kids at home, and does that drug need to be secured? It should absolutely be yes, unless they're just living with somebody else. If you're going to give them medications that come with significant risks like methadone, do you trust them to take that medication the way it's supposed to be taken? You need to get at their medication taking behaviors and make sure that they're going to do what you need them to do so that when you come back for their reassessment, you have a better idea of are they using their medications appropriately, because that's going to drive your next plan. The other thing down here at the very bottom is screening for adverse reactions and potential opioid misuse and abuse, right? And so we don't often think about doing that in our cancer patients, but I'm going to give you 2 pieces of data that should drive this home. What do you think the general rate of a substance use disorder is in the general population, roughly? What % of the population abuses opioids? 10%. What % of cancer patients abuse opioids? 8%. So right on with the general population. And they're predicting, the study authors of this study are predicting really that that's an underreported number, but it's not an insignificant number. 1 out of every 10 patients that you see is going to have a problem with an opioid. You should be asking about those questions, making sure they're taking it appropriately. Are they checking their refills, or are they checking for them early? One thing that we do in some of our clinics is we give 28-day supplies of medications rather than 30 days. This, from a practical standpoint, does a couple of things. One, the refill is always the same day of the week every month. It's during the week, so you shouldn't be getting calls at night or on the weekends. And it's easier to check whether or not they're getting early refills, right? Because if you're doing 30-day supplies and you start January 1, they're going to get 2 fills in January, then you've got 29 days to the end of February, so they're not going to get one in February, they're going to get one in March, versus every 4 weeks. It's much easier for any clerical staff to go, this is too early, right? So think about ways that you can monitor your patients that make things a lot easier. If you're giving 28-day scripts every Tuesday, well, that patient can call on Friday because their refill is due on Tuesday. Or that patient can call on Monday because their refill is due Wednesday. Now you're not getting calls on weekends or evenings, and it's much easier to track that information. So there's a lot here. None of this in the kind of special issues for our patient really made much of an impact. His cultural beliefs towards pain, he really didn't have any. He just wanted to be comfortable. He stated to us repeatedly he wanted to go home. We asked about that information. He was married. He had no children, so we didn't have to worry about storage of medications at home. But those are things to think about that probably are not in your routine questions being asked, but think about start asking those questions. Okay, so let's jump back into it. This is what he was started on by the primary medical team before our service got involved. He was put on a Dilaudid PCA. He was using oxycodone at home around the clock and long acting. He was given 0.2 an hour of a continuous rate, 0.4 every 10 minutes. And over a couple day period, he was ranging between 400 to 600 oral morphine equivalents on his PCA. He stated to us that his pain is well controlled on the PCA. His scores were 5 to 7 out of 10. He was doing what he wanted to do other than eating, is what he was telling us. He was sleeping well. He had no side effects from the drugs. So the question is, how do we get this man home? Okay, so he wants to get home. He's repeatedly told us since he was admitted, I just want to get home as quickly as possible. He's strictly NPO and would remain NPO upon discharge and can't go home on an oral regimen. He doesn't want to go home with hospice, so we can't get him a PCA. What do we do? Okay, Durgesic patches. He tried those. They didn't work for him. Liquid strict NPO, can't take liquids. So sublingual may be a route. Don't forget, you could do rectal. Okay, so think about those things as we're going through this. This is the time at which we're going to just start thinking about throwing the kitchen sink at this guy, because the standard things that we're doing are not going to work for him. I'll say that's Brady, and it probably was complete. All right, so we're going to highlight 4 drugs, okay? There are many others that we could consider, but we're going to go with these first, right? Because we're probably all comfortable with our traditional opioids. We're comfortable with our gabapentinoids. Maybe these are the group that you're not so comfortable with, but this is really where we're going to step into. I'm going to show you my thought process of how I go through these things to kind of open up how you can think about them. So the reason I bring up mixilotine here is it's an oral version of lidocaine if you needed to use it. Okay, so my thought is always safety first. So whenever I'm teaching anybody about this, or learners, or talking about it, it's what is safe first? Because if it's not safe, I can't use it. Then I can worry about, is it going to be effective for that type of pain? And then I get my options of, okay, what's left to treat the pain? So we're going to go through this, and you'll see the chart at the end, and we'll pick a drug from there. So buprenorphine, there's really no true contraindications to this drug other than allergies. So it's kind of the first thing you should think of is, are there contraindications that I can't use it? Next should be, do they have renal or hepatic dysfunction that would limit its use or my ability to use it? There's no adjustments in renal disease. You can use it in patients with severe hepatic disease as well. You just start lower. So from the perspective of buprenorphine, we're fine with this drug. It's okay to use. Ketamine, there are, no matter what anybody tells you, no true contraindications to using ketamine. Depending on who you're talking to, they might tell you contraindications. You can use it in renal and liver patients. These are the ones that you might want to be a little concerned about. So patients with tachycardia or hypertension, ketamine can worsen those. So if it's controlled, generally our threshold is for blood pressure less than 160s. We're okay with that. You're not seeing massive increases in most patients, but you might see some. Tachycardia, if they're over 110s, you should be getting a little bit concerned. And then head injuries. The reason for head injuries is because the number one side effect of ketamine is hallucination. So if you're going to alter their mental status, you might muddy the waters. Question?
Would you view pain-induced tachycardia in the same way?
No. So this would be like somebody's baseline tachycardic from a cardiovascular disease standpoint, not tachycardic because of something I can treat, right? Because of their pain generator. Good question. Lidocaine, it's actually an antiarrhythmic, so don't use it in patients with a significant cardiovascular disease. You don't have to adjust it in renal disease if they have liver disease, low and slow. But the problem with this drug is it has very wide and variable pharmacokinetics. So even though most patients do okay on it, you really have a hard time predicting who's going to respond versus who's going to get a toxic level on this. But it's an option because we can monitor lidocaine levels. Methadone, you're probably most familiar with this drug versus all of the other ones. Don't use in patients with prolonged QT or significant cardiovascular disease or med adherence issues. So a couple things to note about QT. On average, what does the published literature say that methadone prolongs QT by in these types of patients in terms of milliseconds on a QT, on an EKG? Roughly 15 milliseconds. Not a huge increase, right? We think methadone is this drug that just gives everybody torsades. That's not really the case. It's in roughly 1 out of every 5 patients might have an increase in their QT, up to an average of about 15. And so there was a study done of risk factors of patients that had prolonged QT on methadone and they did case control. Having peptic ulcer disease had a higher relative risk of prolonging your QT than being on methadone. Having congestive heart failure had a risk 4 times that of being on methadone. So yes, methadone prolongs the QT, but let's not overblow it. So if they're 475 and under, I'm totally comfortable putting them on methadone. If they're at 500, that's where I say no. And the reason that I say no is because the lowest QT that's been reported for a patient getting torsades on methadone is 517. So I'm really within my error, my statistical error of I start them on methadone, I could put them in torsades if they get that increase. So under 500, I'm okay with doing it and checking a QT. Med adherence issues. This is important, right? Because we know that the PK lags from the analgesic effect. So if you've got somebody that's not going to understand that this is something you take regularly, this is not something you take for breakthrough pain, in 3 days, if they're using it all for breakthrough pain, they're going to overdose from that. So be very careful. So for this patient, all these drugs are still options. We haven't ruled out any of them. Certainly we're kind of thinking one might be better than the other from a safety perspective, but if we monitor this patient closely, we could use any one of these drugs and it's totally fine. So now let's talk about effective. And what I mean for effective is for this patient's type of pain specifically. So you should be thinking about what their pain mechanism is. So buprenorphine is a good drug for nociceptive pain. It really does not treat neuropathic pain. It is just like any other opioid in terms of the receptors that it hits and how it works. The difference is how it interacts with those receptors. And you probably haven't had a lot of talks about the various receptors, opioid receptors in a while, and we'll show you the differences in just 1 second. But we get less respiratory depression and side effects because it's a partial agonist and because it's a kappa antagonist. Those are the big distinctions here. When we talk about traditional opioids, we talk about them all as mu opioid receptor agonists, but really they're actually agonists at all of the opioid receptors. So here we're actually antagonizing the kappa receptor, and we're only partially an agonist at the mu receptor. So if we look back at our receptors, the big difference here is because we're only kind of touching this one, we're only getting some of those effects. And so we're limited in the major side effects of respiratory depression. So studies comparing traditional opioids to buprenorphine have shown that buprenorphine really does not have any risk of respiratory depression, even in patients that are using this for a substance use disorder. But the big difference here is kappa antagonism. So if you are an agonist at this receptor, respiratory depression, dysphoria, dependence, dyspnea, all the things we don't want. But because we're blocking that receptor, it's good for people who have a substance use disorder because it decreases cravings, and it's also kind of a mild antidepressant. But for people with just pain that we're treating, we're antagonizing it so we don't get the bad side effects, which is what we're looking for here, right? So those are things we can take advantage of with a buprenorphine. PK, so one thing to note, a lot of this is very formulation dependent, and buprenorphine comes in all sorts of formulations and routes of administration. Sublingual tablets, some sublingual films, buccal films, transdermal patches, implants. It comes IV or IM. So it comes in any way you want to give it. You could probably find a way to give it. It's really only 50% bioavailable. And I'm putting naloxone up here because I think there's a big misconception about when we have somebody on Suboxone, which is buprenorphine and naloxone. Why is the naloxone there? Why is it there? What's its purpose? I know there's pharmacists in the crowd, so I kind of want to point at them, but I'm not going to. Yeah, right. So the common misconception is that naloxone is there and that it's going to prevent abuse. It's true, but only if they're going to melt it and inject it. So some brief history is this used to be over in the United Kingdom as just buprenorphine, and they were finding that a lot of people were injecting it to get themselves off of heroin. When it was brought to the States, they added naloxone to prevent people from injecting it and abusing it. It has nothing, like there's no role for it if you're taking it orally. Like it does nothing. It's not bioavailable. It's not gonna hurt the patient. It's not gonna change their oral morphine equivalents. It won't put them into withdrawal. Its sole purpose is to prevent IV abuse of the drug. But a lot of people will say, oh, that's Suboxone, that's for drug abuse. Well, we choose Suboxone because your insurance company says it's the cheapest one, and I don't really care what the naloxone does because it's not really in there, because it's the same drug as the ones without naloxone in it. The analgesic effect is about 6 hours, so this is a drug to dose 3 times a day for pain. You can go up to pretty high doses with this. The max daily dose is really 32 milligrams total in a day. I'll tell you that if you're hitting 24 milligrams total in a day, you're probably maxing this drug out because you've saturated enough receptors that you're not going to get much more pain benefits outside of that. Bup, for this guy's pain, is probably going to work, right? So he's got his chronic back pain, that's not neuropathic. He's got his visceral pain around his G-tube, which is neuropathic, so we're not necessarily going to treat that, but his primary pain generator is his chronic back pain. He also has the abdominal pain that we're not totally sure what's causing it, probably a recurrence of his cancer at this point, but an opioid, if it's treating that pain, buprenorphine would also treat that pain. So let's talk about ketamine. So ketamine treats both nociceptive pain and neuropathic pain. It's an interesting drug. It's an NMDA receptor antagonist and also functions as kind of a mild SNRI. So does anybody know where the NMDA receptor is and how this actually works for pain? Why is this an important concept? So it works in 2 different ways, right? So there's the NMDA receptor and then there's SNRI activity. And so NMDA blocks glutamate excitatory signaling. So pain is really an excitatory process of the central nervous system. So it's blocking that. The other side of this is SNRI activity. So noradrenergic receptors in our descending pain pathway, in normal patients, descending pain pathway blocks pain signals from getting to the brain. So not only is ketamine stopping them from getting up to the brain, but it's also helping the brain's ability to stop those signals in both directions. So it's working on both the ascending pathway and the descending pathway, which is a little bit different here. In more detail, we think it might be a minor opioid agonist based on some rat studies, but we don't really consider it to be within the opioid family. What we really think clinically is happening to these patients is that for patients that have nociceptive pain not responsive to opioids, is that we're resetting that pathway, thereby making their opioids more effective for them. It also has some primary function on neurons, but we're really thinking that we're just kind of helping their CNS regenerate quickly. And so what you'll see when you start patients on ketamine is that if they respond to it, their oral morphine equivalents drop pretty dramatically within a couple of hours. That effect can last anywhere between 2 to 4 weeks if they're a responder. So here's a little bit more detail about NMDA activity. It also, like I said, works for neuropathic pain. So although he has visceral neuropathic pain, when you think of ketamine, you should think of refractory primary neuropathic pain, so not a mild visceral one, but we're talking like severe chemo-induced neuropathy, unresponsive to other drugs. That's more kind of the true path that it's working. His little visceral pain would be a really good pain for a gabapentinoid because that responds really well to those. Unfortunately, he can't take that. PK is interesting, and I'm going to highlight a couple things for you. So it has really low oral bioavailability, but it's an odd drug that if you're going to use IV and oral, you actually use less oral than you do IV, right? So typically we'll say you need more oral to make up for IV potency, but it's an interesting drug in that when it goes through rapid first pass metabolism, and what that means is that its active metabolite norketamine for patients taking an oral version of it, they get 3 to 5 times more concentration of that than if they're given it IV. And so, as an example, when we're dosing IV ketamine, we're using like 0.3 milligrams per kilogram per hour, and then we add that up total in a day. Say they're on 240 milligrams total in a day of IV ketamine. We're gonna take that and only use 25% of that and then divide that out 3 times a day. So most patients for oral ketamine are starting at like 15 milligrams 3 times a day. So their total daily dose is 45 versus somebody getting a continuous infusion is getting usually north of 200 because of this rapid first pass metabolism. The oral version is literally just the IV vial put in with an oral syringe. So there's nothing actually different about it. But its most important PK part is where it distributes first. So brain, heart, and lungs. You should remember this because this is the side effect profile of this drug. So brain, people get hallucinations. Heart, people get tachycardia. Lungs, there are some patients that get respiratory depression from this drug. Right? So those are the 3 major side effects. They're easy to treat. So patients that have hallucinations, how do you treat hallucinations that are induced by ketamine? Ativan. Yep. So any benzodiazepine would work just fine. We typically choose Ativan just because of how long it lasts. So if you're going to start somebody on ketamine, it's a good idea to have a PRN benzo available for them, just a small course if they're going to get hallucinations. The tachycardia and hypertension can be treated just like you would treat anybody else's. Respiratory depression, you have to stop the drug. It's liver metabolized, renally eliminated, but we don't have to worry about those. And then the nice part is once we give it IV, we typically know within about the first 4 hours whether or not that patient's going to respond. If you're going to start this as an oral drug, you're going to need to give it for about 3 days to see if they're going to respond, because you're going to need to slowly up titrate that drug because of the amount of norketamine available. So from an effective standpoint, this would be a drug we could use. It's going to hit all of his pain generators that we could treat. It's IV, so we could give it to him. Lidocaine is a sodium channel blocker. And so if you remember back when you were probably an undergraduate or in high school, you remember action potentials, right, along a neuron. Action potentials are driven by sodium-potassium channels. That's all lidocaine does, is it slows down the propagation of action potentials along neurons. It's a really simple drug from that perspective, but that's how it works. And because pain is generated along our neurons up to our central nervous system, that's all it's going to do is just slow those signaling pathways down. It has high oral bioavailability if you give it as mixilotine. The only difference really between this and if you're giving somebody like ketamine to oral ketamine versus lidocaine to oral mixilotine, you should only give mixilotine to people who have responded to the IV version of lidocaine, because the studies have shown that you need to see a response before you're giving them mixilotine. Ketamine, you can start either IV or oral, it doesn't matter, one after the other, there's no difference. This is a difference between this drug and many others. It's liver metabolized, its elimination is biphasic, and this is where it gets a little muddy, and so you should be getting levels every 8 hours. We, at Michigan, we don't actually require that these people are in units, we do it on the floor now, which is a big change, but a lot of hospitals across the country are doing this because it's just easier. If you're on mexilotine, you don't need to check levels because you've already made sure that they've responded to the drug, they're stabilized on it, and then you're giving them really a low dose to sustain that response. Lidocaine would work for his pain. He's got neuropathic pain, he's got nociceptive pain. We haven't eliminated any options just yet. And most of you are familiar with methadone, so we'll go through this a little bit faster. So mu agonist, NMDA antagonist, and it's also a mild SNRI. It is 80% bioavailable after oral administration. Its rectal bioavailability is also high. You can give this drug any way you want and it's really going to work. It's rapidly absorbed. It's a nice drug from that perspective. This is where it starts to get muddy. It's super lipophilic, so even the IV version of methadone is long acting. The reason that is because of the drug, in that it sits in your fat tissue and then slowly leaches out. Versus something like an OxyContin, the manufacturing company reformulated how the drug releases from the pill. That's not the case with methadone. So it's our only naturally long acting, regardless of how you give it. So you can give the IV methadone 3 times a day, just like you would oral, or even twice a day, and it's gonna act the same way, which is really a nice advantage of it. The problem is that it has a large volume of distribution, and we don't know everybody's half-life because it can be prolonged. So we generally think that people that are larger are gonna hold on to the drug longer, but we haven't really shown that yet in the literature. We did an internal survey of our palliative physicians and whether or not they dose reduce because of drug interactions, and they're all over the board. So everybody's kind of doing their own thing. We standardize that where we're at to stop that. But there's a couple tables in here that are a little handy for you, but you'll understand why everybody's all over the board. So if you're to put methadone and any of these drugs into a drug interaction checker, this is what you're gonna see. You're gonna see that fluconazole, on average, increases methadone levels by about 35%. You should generally dose reduce by about 1/3. Then you'll see all these other drug interactions, and then there's no guidance on how much they're changing methadone. So it's like, maybe you should, maybe you shouldn't, we're not sure. Here's another table for you. Phenytoin and ritonavir actually decrease the amount of methadone, so it's inducing its metabolism. We don't really make a lot of changes. So our general rule of thumb as just a safety practice is if there's an interaction that's gonna increase methadone, we drop the dose by 1/3. If it's gonna decrease methadone, we don't change anything. We see how they go on that drug and then increase it if they need it later. Because the data just isn't out there to say what really the best practice should be. So think about however you're doing it. There's really no good way to do it. We've just done that because we have multiple physicians all doing different things, but now we know what everybody's gonna do. So if we're switching hands, we know what the previous person was doing. From an elimination standpoint, long variable half-life, it comes out kind of everywhere. And so this is the problem with methadone, that if you're gonna switch somebody off of it, it gets a little bit ugly. So if you're putting somebody on methadone, that's gotta be the consideration. Is this a drug that I'm gonna be able to use for a long period of time? Because trying to get them off of it might be a little sticky. It's gonna work though. So we haven't eliminated any drug yet from an effectiveness standpoint. So now it's what is best for this guy in this period of time right now. So we're good everywhere. So let's think about why each one of these might be the best drug for him. And then we'll see what the group would do, and then I'll tell you what we did. So buprenorphine is nice. It's sublingual, so we could give it that way. He could go home with that. It's parenteral, so we could give it fast and get him off of his PCA if we needed to. It would decrease his opioid-related risks, right? So he's using 400 to 600 oral morphine equivalents. It puts him at risk for things. It would get him home. It's not necessarily going to treat all of his pains, but we can deliver the drug to this guy in an easy way. Ketamine, we can give him IV ketamine. We could see how much we could drop his oral morphine equivalents. We may not totally get him off of opioids, but maybe we get him to a point at which he's using very little. It's an option. If he responded to it, we could always give him oral ketamine if he gets off of his NPO status. And we really actually think that part of his abdominal issue is that he's on so much opioid and he's locked up his bowel. So if we can get his opioids down, we think we might also resolve some of that abdominal pain. Lidocaine, we can give it IV. We could give oral later. It's about the only advantage of that right now is that we can give it IV. Methadone, we can give this any way we want. We could put him on sublingual, we could give it to him rectally, we could give it to him IV, same drug, inpatient, outpatient. It'd be a nice transition for him. So right before we made the change, he was using 26 milligrams of IV Dilaudid through his PCA. Now his pain scores have gone to 9 to 10, and so this is a slight escalation in his oral morphine equivalents, but his pain has started to get slightly worse. So what do you do now? Your answer is that it's got to be one of these 4 drugs because that's what we're talking about. But what would you choose and how would you do it?
Could he be developing opioid-induced hyperalgesia, in which case maybe methadone would be a good option?
Okay, so maybe we think he's hyperalgesic now and methadone would be a good idea. Okay, reasonable.
Give lidocaine, give it IV, and it might help get him out of the hospital.
Okay, so maybe we try lidocaine to get him out of the hospital and get him home because that's what he's wanting. So the first question that you should ask yourself, and that I didn't prompt you with, is why is his pain all of a sudden now a 9 out of 10 to a 10 out of 10, when before, for the first couple of days of admission, once he was on his PCA, he was 5 to 7 and was fine. So maybe he got hyperalgesic. He started eating again. So he started eating in the hospital without telling anybody. He was sneaking food, making his pain worse. So he wasn't hyperalgesic, but it reminds you that your pain assessment needs to happen every time you're going to do anything, right? So it's a good thought to think, why all of a sudden did his pain change? What other factors are happening here?
Would it be anxiety of him going back home without the hospital?
No, he wanted to go home. He was anxious because he was in the hospital. He wanted to get out of there. And it really, what we boiled it down to is he just started eating again because his pain was so well controlled that he was like, I'm just going to eat. Forget this. This is a quality of life issue. He started eating again. But we didn't find that out from the primary team. We had to go in and ask lots of questions. But it's a point to you to remember, always reassess, even if you think you've got it nailed, there might be something throwing you off. So, okay, so now knowing that, he's eating again. He wants to go home. What do you do now? The GI team would not allow us to give him anything through the GJ.
What was using buprenorphine in sublingually?
So sublingual administration or rectal administration. We offered both. He said, nope, sublingual is the way we're going to go, which is like everybody. Right? So we gave him buprenorphine because we thought this was the fastest way to get him home. He was responding to his opioids before he started eating again, and we're still hitting all of the same receptors just in a different way. Right? And so this is how we did it. We stopped his PCA at 2 o'clock in the morning, and then at 8 o'clock in the morning, we were going to give him 1 milligram of buprenorphine sublingually every 30 minutes for 4 doses. And then we're going to give him 2 milligrams every 4 hours for 4 doses. Then that next day, we were going to start him on a maintenance dose. Okay. We also gave him some Toradol because no one had done that to that point. So we thought that might also help. What do you think of that dosing? Does that seem normal? Seems kind of weird, right? So we're taking a guy with horrible cancer and we're just stopping his PCA for 6 hours, and then we're going to give him small doses of buprenorphine. Why do you think we did that? I'll tell you, we did the right thing, but why do you think we did it that way? So remember the difference between Dilaudid or hydromorphone and how it works, and buprenorphine, right? So full mu opioid receptor agonist, meaning that if you're kind of to graph this out on a chart, you're activating that receptor completely, whereas buprenorphine is only going to hit it, let's say, halfway. So if you are to give somebody a full opioid agonist and immediately give them a drug that only agonizes that receptor partially, but does it at a higher receptor affinity, you're going to put them into fluid withdrawal, right? So what you try to do is you try to mildly let them come into withdrawal and then replace them with buprenorphine, because buprenorphine has really high receptor affinity. So it's like musical chairs, but playing it against like defensive linemen who are going to knock you off the chair, right? You don't want to get into that. You want to let them dance around a little bit. So the point here is to try to get them into first signs of mild withdrawal, give them buprenorphine to start replacing it, so that once it starts displacing all of the hydromorphone or other opioid, it's doing so at an equivalent level. So really, this was our plan. What ended up happening to this guy is at 7:30 in the morning, he started having signs of withdrawal. So we moved our plan up 30 minutes. After 2 doses, he was out of withdrawal. We kept with this plan to load him up in buprenorphine to replace all of his hydromorphone. And then the next day, the target doses that you use are variable, usually anywhere between 3 to 4 milligrams 3 times a day. We started him, so we did this, and so he got 4 milligrams up front, and then he got 8 milligrams later. So he got 12 in a day. So what we did was we gave him 3 milligrams 3 times a day, scheduled, and then gave him 1 milligram to use 3 times a day if he needed it, to see where he would land. He ended up using only 2 of those doses the next day. So what we did was we went 4-4-3, and then gave him 2 milligrams to play with. And then he ended up using it and using it. He ended up on 4 milligrams 3 times a day and thought his world had changed. He was ready to go. And this is the last slide, but what do you think ended up happening to this gentleman? He started eating again. And he totally screwed our plan up. It would have been a beautiful case report for this guy, but he started eating again. And his pain got way worse, just like it did before. And so the discussion was, why is your pain getting worse? Like, everything worked perfectly for you. It went the way, with the exception of about 30 minutes of being off in our initial guess, it went the way we thought it was gonna go. Everything worked really well for you. Then your pain got worse because you were eating again. He then finally came to the point that eating is really important to me. So, but he had been adamant up front that he did not want hospice. And so we said, the only way that you're gonna eat is if you go home with hospice and we can give you a PCA. So then after all that work and getting him on buprenorphine, we put him back on his Dilaudid PCA. He went home with hospice. He ended up dying a couple weeks after that. But it shows you that thinking through all of these steps, there are ways to give drugs to people that you may not consider. And we don't traditionally consider giving buprenorphine to cancer patients, but it's a drug that works for many people.
I have a question on this. Why does a patient have to go to hospice to get a PCA? Wouldn't the home health do that?
Not in our area. No one's going to cover it. We have not had any success getting anybody on a home PCA unless they're going home with hospice.
Can I ask you how to talk him into that?
Talked him into the buprenorphine.
Talk the patient into discontinuing his PCA for that many hours. I mean, he couldn't have been really receptive to that as soon as you told him you were going to put him on orals many hours later.
So it was all getting back to his goals of care. And so the reason we choose certain times is on purpose, right? So we did this overnight so he was sleeping through most of his withdrawal. He woke up then experiencing his withdrawal rather than doing this in the middle of the day. And so it gave us a couple of advantages. One, he slept through most of it. And two, everybody's in the hospital at 7 o'clock in the morning versus like later in the day. So talking him through the process was simply, this is what we expect to happen, but we expect your pain to significantly improve within the first day. We expect your withdrawal to go away within the first couple of hours, and this will get you home. And so it was really driving the point that this is going to get you home. That's what you've been asking for. This is our best way to do it. He bought into that.
Nicely done. What's the cost of the drug?
Of buprenorphine, pennies on the dollar.
Oh, nice.
Pennies on the dollar. It's very cheap. Depends on insurance, but most insurance will cover one version of buprenorphine. It could be Subutex, which is just buprenorphine. It could be Suboxone, which is buprenorphine naloxone, but it's wildly inexpensive. The caveat to that is Butrans and Belbuca. Butrans is a patch, Belbuca is a buccal film. Those are only FDA indicated for people with chronic pain, and they come in microgram versions. So what that means is if you've got a patient on less than 80 oral morphine equivalents, you can use one of those too because of microgram dosing. If you have somebody on more than 80 oral morphine equivalents, which is most of your people with cancer, you're gonna have to use milligram versions, which is your Subutex Suboxone.
Do you find that you're dealing with somebody as an inpatient, dealing with somebody who mentioned insurance? Do the insurance requirements, would they change what you offer?
It would change simply which formulation am I going to give him, not going to change our decision making because the drug is so cheap here, and really all of them are at this point. They've all been around for a while, so it's not a problem delivering that medication. I'll say the problem with with buprenorphine, if you're doing it, so if you're not going to be then the person prescribing it as an outpatient, is finding somebody that's comfortable prescribing as an outpatient. So this guy is somebody we were going to take over in our clinics, and we were going to take it over, but that's not often the case if we've got somebody from outside of our kind of service area. I'll say getting people comfortable with buprenorphine for me has been like a 4-year battle of just like dragging people across the line. But now I've got a bunch of providers that are asking me, hey, can I use buprenorphine in this guy? And I'm like, yes, you can, let's do it. It just takes doing it a couple times with some support.
You need a special license if you're doing it for cancer pain rather than substance use disorder.
No. So if anybody can prescribe buprenorphine for pain, it is off-label for pain. If you're using Suboxone Subutex milligram versions. If you're using it for substance use disorder, you need to be X licensed, but you do not need any special licensing or training to prescribe it for pain. And so a little handy trick is if you're prescribing it as an outpatient, write on the script for pain, or that pharmacy is going to call you and bother you and say, you need an X license. And you're going, no, I don't. So just write for pain on there.
I see a lot of topical ketamine being used for neuropathic pain. Is it any benefit?
It is voodoo. I'll say I've got
Care people that are prescribing it.
I've got an N of 1
Yeah.
of this is a 35-year-old kid who has severe peripheral arterial disease to the point that he's auto-amputated many of his digits. He had a right BKA because of it. Like I'm talking like, so finger as an example, got paper cut, got infected, lost finger. That was the same, he stubbed his toe, ended up getting necrotizing fasciitis, needed a BKA. Like that's how bad his disease is. He was having really bad neuropathic pain of his hand. We had him at one point up to methadone 30 3 times a day and using Dilaudid as he needed it, and it really wasn't doing anything. We put him on a combination because we were like, this is the kitchen sink now, like this is what's happening, of topical ketamine, lidocaine, and amitriptyline. It worked great for him, but it was like $1,500. So he got 1 tube of it because his hometown pharmacy was like, we'll just make it for you and you can take it, but we can't eat this anymore. That's my only person that's actually worked on. No one else has actually worked on. I don't know that it actually worked on this guy now. He's down to 15 BID of methadone and no issues because like all of his pain generators like come up and down. But topicals by and large don't work. They don't get absorbed to the degree they need to. Other questions? I'll say we ran a study, we haven't published it. We looked at 30,000 patients coming out of our cancer center, and we were about 4% people being diagnosed with a substance use disorder, which is probably low because that was simply based off of diagnosis codes. But the point I'll highlight is that for those, we used less than 1% of patients got universal precautions, so like a controlled substance agreement that says like, don't do this. So we're not even using universal precautions, everybody, for cancer patients, even those people that, and this was, the rate of getting one of those before or after the diagnosis of a substance use disorder didn't matter. So like even after somebody gets diagnosed, like you're abusing opioids in cancer patients, we're still not going, here's a controlled substance agreement, like don't break this. I think because we're trying to be nice, but really a CSA or those universal precautions are being nice. You're protecting them from harming themselves. But it shows that we've got a lot of work to do kind of in that addiction space, particularly in people with serious illness. Well, if there's no...
Dosing and benefit of corticosteroids is an adjunct to pain. You see a lot of people, again, by failure of care being put on pretty significant doses of steroids.
Yeah. So there's this really nice paper on how to manage corticosteroid side effects out of a group of Michigan. You might be able to find it if you look at an author name that's on the slide. But all jokes aside, there's data that says that if you we do a really bad job at giving people steroids, you should give them high doses initially and then just back them down. right? So pretty typically the cleanest drug from a side effect profile and effectiveness for as an adjunct is dexamethasone, but often we're kind of monkeying around with like 2 to 4 milligrams twice a day, when really you should give them 8 milligrams twice a day for a couple of days, then back them down to 4 twice a day. But those effects really only last about 2 weeks. So prolonged courses of steroids are people not knowing what they're doing.
Yeah, I was just gonna ask a little bit, I know at Michigan we've had issues with like IV lidocaine of whether we can do it on the floor or have to transfer them to the ICU. Could you talk a little bit about like your experience with that makes you like shy away from choosing lidocaine as an option?
Yeah, so history to that this has been going on for years, because if you've ever worked at the University of Michigan, trying to change anything is like trying to move a mountain. And so previously, our institution, only the pediatric palliative care service and pediatric pain service could use lidocaine, and they could really do it on anybody. They actually use, our ped service uses lidocaine over ketamine, just to give you an example of like who's using what. Our adult side tends to use ketamine more than lidocaine. And so we've been revising our policy for a year and a half now. And even during revising the policy, we're still using lidocaine on the floor, even though the policy hasn't officially been approved to use it on the floor. But there's a number of other institutions, Stanford as an example, uses it on the floor. I don't actually consider that an issue at all. I think it's better that they stay on the floor, because some of my concerns with getting people to units for certain drugs, like Precedex as an example, is I think then people become hyper-focused on somebody's pain and are just reminding them of things that they don't need to be reminded about. So if they're in a comfortable environment on the floor, everybody's fine. I prefer to keep them there if I can. And that was one of the impetuses for pushing lidocaine to be used on the floor, because it's a safe drug if you're checking levels. So I don't even think about that anymore.
Is there high acuity for the nurse for management of that patient?
Nope. It's no different than them getting oxycodone every 4 hours. All right, if there's no more, oh.
You added Toralac to his legend.
Mm-hmm.
Is there an anti-inflammatory that you would not use? Cofanac, or are there ways to sort of?
Like parse out which NSAID to use or which anti-inflammatory to use. So I'll say that I have to give another talk to a whole different group on picking NSAIDs or Tylenol. And really, if you look at the data on NSAIDs, we used to think that whether it was COX-1 selective or COX-2 selective gave whether or not it was going to have a cardiovascular toxicity or not. We know that's not true now, right? And so we used to think celecoxib was bad for people with heart disease because of the APC trial. And really, if you looked at the data, it was like a risk of a cardiovascular event of about 3% over that study period, which isn't huge. But the really interesting piece of data is that cardiovascular risk starts with first dose and remains about the same throughout whatever treatment period you're giving them. So from a cardiovascular standpoint, there's really no way to differentiate them. From a gastrointestinal standpoint, you can differentiate them a little. I tend to not. My kind of way that I split them is what's going to be easy for the patient to take. I'm a big fan of Mobic for a lot of people. Once a day seems to work really well. I've got no issues with it. The only time I'll move off of that is Motrin for people who are on dialysis. So everybody, hopefully there's no nephrologists in the room, but you can totally use Motrin for people on dialysis because it gets removed by dialysis. Most of the other NSAIDs don't, but that's an advantage to that drug. Really, it's picking what you're most comfortable with. We could parse out all of what doses are effective, so as long as you're using an effective dose, so 2,400 milligrams of Motrin in a day is where you're at. Really, if you look at the data across any study, whether it's single dose postoperative, chronic pain studies, you have to use the max daily dose of really any one of the NSAIDs for it to show a clinically significant decrease in their pain. So as an example, there's a study that looks at, you should Google it sometime if you have time. It's called the Oxford Table of NSAIDs. And so they put together all sorts of post-surgical data and combined what appears to be this very large table of what dose an NSAID does and how much it reduces pain. So as an example, 400 milligrams of ibuprofen as the dose reduces pain in roughly 2/3 of people. 600 gets to roughly 3/4 of people, and 800 gets nearly everybody. But the number needed to treat between 400 and 600 is no different, but the number needed to treat between 400, 600, and 800 is different. You only need a couple for 800, whereas you need nearly double that for people on 400 to 600. So to me, what this tells me is not necessarily that I need to pick a certain one, but I better use it right before I call it a failure. And oftentimes we're not seeing that. So we chose Toradol for this guy solely because we could give it IV.
Find the same thing with gabapentin and the GABAergic drugs that we tend to underdose and then abandon before we reach that maximum.
I don't think we underdose gabapentin. I think we don't dose it appropriately for its side effect profile. So you should be loading night doses because it'll make them sleepy for a week and it generally goes away. But we often abandon it in a week and say, it doesn't work. And then we're jumping to Lyrica. The nice thing now, Lyrica is generic, so it's a lot cheaper than it was. And there are studies that switching from gabapentin to pregabalin, those people tolerate it even if the reason for stopping gabapentin was a side effect. They're more likely to tolerate Lyrica. Most insurance companies are still requiring we use gabapentin, but I find that the biggest problem is we abandon a drug and say it didn't work, and then that's stuck in that patient's profile, well, this drug didn't work. Well, A, what were you using it for? B, what was the dose? And C, what was the reason that you stopped the drug? Because if the pain is different, or the dose was inadequate, or you weren't given a fair trial, we're then writing off drugs that we shouldn't be writing off. Any other questions? All right, thank you for your time.